Welcome to today's webinar, Air Quality in Infection Prevention Imperative. Today's presenter is my favorite speaker of all times, Maureen Spencer. Maureen is a registered nurse with a master's degree in education and board certified in infection control. In 2007, she was a recipient of the APIC Heroes of Infection Prevention, and in 2012, she was selected as one of the who's who of infection prevention. In 2017, she was recognized as a fellow of the Association for Professionals in Infection Control and Epidemiology for her advanced practice in infection prevention and, of course, leadership within the field. She is currently an independent infection prevention consultant from Boston, Massachusetts. Maureen has published numerous peer-reviewed publications and has presented many abstracts and posters at conferences. She's a national and international speaker on an array of infection prevention and control topics. Her previous positions include Director of Clinical Education at Accelerate Diagnostics, Corporate Director of Infection Prevention for Universal Health Services, Infection Control Manager at New England Baptist Hospital, and Director of Infection Control at Mass General Hospital in Boston, Massachusetts. These are Maureen's disclosures. She is a speaker providing clinical consulting services to Aerobiotics, and in conjunction with Aerobiotics team, this presentation was developed. This is the information regarding how to obtain continuing education credit. Terry Goodman and Associates is an approved provider by the California Board of Registered Nursing. In order to earn a certificate for 1.2 contact hours, you must miss no more than 10 minutes of the webinar and complete an online evaluation, which you will receive by email within 48 hours. If you don't receive the email, please check your spam folder. And if it's not there, please contact Terry at terry@terrygoodman.com.
Air quality and infection prevention imperative. My name is Maureen Spencer and I'm an infection preventionist consultant. Learning objectives for this webinar. Number one, to demonstrate the relationship between contaminated air and infection associated with implantable devices. Two is to examine the evidence regarding the role of air decontamination in reduction of surgical site infections. Three, will explore strategies to reduce the risk associated with airborne pathogens. And four is to describe adjunctive technology that's designed to reduce the risk of surgical site infections and SARS-CoV-2 airborne transmission. There's an increased risk of surgical site infections with implant procedures. Procedures involving an implant pose the greatest risk of infection from just the smallest amount of an inoculum. A foreign body such as an implant can reduce the number of organisms needed to cause an infection by a factor of 100,000. And organisms that are typically skin flora are dispersed in the operating room on air squamous epithelial cells that then can settle in the open incision and adhere to the implant. Air contamination and surgical site infection has had nearly a century of peer-reviewed literature that supports this relationship between the airborne pathogen levels and surgical site infections. Now, some of those key risk factors involve the number of people in the room. Also, the number of times those doors are being opened going into that operating room, moving exogenous contaminants towards the field. There are other facility risk factors that may be involved with the air handling system. Length of the procedure time is a risk factor. The instruments obviously will get contaminated if you have a longer procedure time and more door openings. And also there's an increased risk with certain procedural types. Now, there have been recorded outbreaks from bacterial-laden skin scales. In this outbreak, 8 infections occurred after modified radical mastectomies in a tertiary care hospital with group A strep that was isolated from the patients. And the outbreak is believed to have occurred by airborne transmission from those scales, we call them skin squames, from actually the colonized surgeon, which then led to shedding and aerosolization that eventually inoculated the operative field and led to those infections. SSIs from bacterial-laden skin scales are often implicated from the source of being in the nose or attached to squames that shed from the skin. And these are less than 5 microns in size. What happens with these particles, they become what we call transiently airborne, and they move around on platforms around the operating room, and they eventually get picked up on the air currents as these doors are open and closed and the beams are moving around the field, and they're passing instruments, and this is how these transient airborne particles land in the incision. We also have documentation of transmission from respiratory aerosols. In this particular report, a physician was colonized intranasally with Staph aureus, and it exhibited a 40-fold increased airborne dispersal after acquiring an upper respiratory rhinovirus infection, and he became what we call a cloud adult. There have been other outbreaks of SSIs that have been caused by other organisms such as MRSA and Staph aureus that have been associated with viral upper respiratory tract infections in a phenomenon of airborne dispersal called the cloud phenomenon. Now here's a question for the audience. An inoculum of what size is required to cause an implant infection? 1,000 colony forming units, 100 colony forming units, or 10? And the answer is 100, just 100 colony forming units that land on an implant can lead to an infection. Look at OR air bacterial level and risk of SSI. There's a 2.6 increased risk of infections, especially in joint replacements, if room air has more than 50 colony forming units of bacteria. We preferably would like to have the air less than 10 colony forming units of bacteria. Now here are some blood agar plates. We call these air settling plates that I actually did in an orthopedic hospital at the end of the case. For 1 hour, I left these open to the air. One was on the anesthesia cart, the Bovie cart, and the computer cart. And you can see how many bacteria were floating while they were closing up the case. And this is what can lead to that biofilm as the bacteria attached to different devices, including not only the implant, but the sutures. And then you can develop biofilm that could lead to an infection. So at the end of the case, we typically see, especially in teaching hospitals, the surgeon will often leave the room so they can start another case. And then we'll hand over the case to maybe the resident, the physician's assistant, or maybe a nurse practitioner that works with them, and they will then close the incision. But you'll see at that end of the case where I showed you on those blood agar plates, there's a lot of activity that starts to occur that can create air turbulence that can result in contaminants settling into the operative site. You may have circulators that are counting their sponges. The scrub techs might be working with the instrument reps to get everything into the trays to go back to central processing for sterilization. Anesthesia staff might often be giving each other breaks, coming in and out of the room. Instrument reps also might be moving in and out of the room to get into another case. And you may have students and visitors. But towards the end of the case, there's a lot of activity in the rooms that can settle as exogenous contaminants into the incision. Let's look at surgical disciplines that place implants. We have breast implants. Plastics uses a lot of different kinds of devices as implants. We know orthopedics has implants, spine, general surgery like hernia mesh, OBGYN such as pelvic floor mesh, and even cardiac surgery with pacemakers, stents, valves, IADs, and you have to even consider the sternal wires on the sternum as an implant. Prosthetic joint infections occur about 2.18% that become infected. One study cost ranged a single case of prosthetic joint infection of anywhere from $389,000 to up to $474,000 in this one-way sensitivity analysis. They can be associated with much higher mortality rate, anywhere from 2 to 7%. And experts report that the 5-year survival rate of patients with a prosthetic joint infection is worse than most cancers. Here you can see the historical and projected number of infected total hips, total knees, and total together may occur going forward in the United States. Hernia mesh implant infections have been reported to be as high as 6 to 10%. Preoperative administration of a single dose cefazolin for prosthetic hernia repairs does not markedly decrease the risk of wound infection, shown in one study, and the outcome of patients treated for chronic mesh infection is unsatisfactory, with high risk of recurrent herniation and development of further chronic abdominal wall sepsis. Spine implant infections can occur after lower back fusions. They have more invasive techniques. With the fusions, have a lot of instruments, as you can see here, with screws and plates. They have a higher rate of SSIs because the bacteria can adhere to all of these little crevices and devices and produce what's called biofilm, this polysaccharide biofilm that acts as a barrier against our host defense mechanisms. So both the immune system can't get in to destroy the bacteria, and the antibiotics cannot penetrate the biofilm to kill the bacteria. In plastic surgeries, in cases that are complicated with an implant, such as women undergoing breast augmentation, have an increased risk of SSIs. Range of reconstructive surgery is higher and can range anywhere from 6 to 28% based on few reports in the literature. There's an increased risk of surgical site infections in breast surgery with implants compared to other clean cases. And unfortunately, this is not one of the SSIs that is reported to NHSN, that we would have routine surveillance being done, that we could have better data on it. So that's why we only have a few reports in the literature that show us in various studies from institutions what their infection rates were with these types of implants. Now here's a fascinating outbreak, the outbreak of Mycobacterium jacuzzi. And in this situation, it was a case control study looking at it. In that situation, they looked at a group of patients who did not get infected, and they compared them to the group of patients that did get infected. And they looked for risk factors. And what they found in this situation, that these identical biochemical profiles of this Mycobacterium walenskyii, okay, but they then named it jacuzzi because they found this isolated from the infected wounds of not only the patients, but they then found it in the eyebrows, the hair, the face, the nose, the ears, and the groin of this particular surgeon. And then they went and looked for environmental sources and found it was in his outdoor whirlpool. So this is why this outbreak shows that the possibility of colonization of the human skin of the surgeon can then occur in transmitting it during surgery. Cardiac implant infections, such as pacemakers, implantable cardioverter defibrillators or ICDs, and implanted heart rhythm monitors called loop recorders, can get infected. Despite improvements in cardiovascular implantable electronic devices and their design, the application of timely infection control practices and administration of antibiotic prophylaxis at the time of the device placement can continue to get deep pocket infections that can then lead to a bloodstream infection or then a life-threatening situation like endocarditis. You know, there is one vendor I know that has developed an antimicrobial coating, a little pouch that you can put the device in. You know, they're trying to figure out ways to get an antiseptic action in the local wound beds to prevent these types of infections. Here's another fascinating outbreak that happened a few years ago. We all had to investigate. And this shows a video image that got captured of a heater cooler unit with smoke dispersal in a cardiac surgery room. And this was part of the transmission of Mycobacterium camarae during cardiac surgery, despite an ultra clean air ventilation system in that hospital. The heater cooler devices are used during cardiovascular surgery to warm or cool the patient. So they don't have a direct contact with the patient, but they have tanks in them that provide this temperature controlled water, the external heat exchangers or to warming cooling blankets through these closed water circuits. The source was airborne as it moved off the machine and into the air and then landed in the incision. But investigation by the CDC and a lot of other investigators, including the company, actually determined that this particular model, the Stockett 3.2 heater cooler unit, was actually contaminated during the manufacturing process. Since 2013, there have been over 100 cases of this unusual non-tuberculous mycobacterium. It's caused prosthetic valve enteritis and disseminated diseases that have been notified throughout Europe and the USA. They linked to contaminated heater cooler units. And the majority of the cases occurred after valve surgery or aortic graft surgery. Nearly half resulted in death. And 2 cases actually have been reported with left ventricular assist devices. So as that particular outbreak and the ones I've just shown you, you can see where the operating room air can be involved with outbreak situations. And so when we're going to look at the operating room air quality in the US, and here's just a picture of what a new UV air decontamination filter looks like, and just after 1 month. And here's actually one of those blood agar plates that I had put next to the exhaust vent to demonstrate to the staff why the air was not being able to be taken out through the filter to be recirculated. They had so much equipment up next to this exhaust vent that nothing could get out. And so you could see what was settling on the plates, meaning that it was continuing to be settled in the room. We have challenges in today's operating rooms that impact our air quality. We have many more procedures on schedules. And as things are getting ramped up now, we have faster turnovers. They want to get more people on the schedule to do more cases, more personnel, more activity and equipment, increased door openings as a result of that, increased use of implants in all types of surgical specialties. We have more implant revision procedures that have to be done if they're infected, more antibiotic-resistant organisms as a result of these SSIs. And we have a lot of older and more vulnerable patients who are undergoing, especially joint replacements. Now, what's interesting about air quality, it's very different in the operating room versus the pharmaceutical industry, where they have to have very strict enforced air quality standards in their manufacturing processes, but we don't have the same for our operating rooms. U.S. compounding pharmacies must comply with the International Standards Organization, or ISO Class 5 standards for air quality. These compounding pharmacies prepare sterile solutions that are going to be introduced into a sterile vascular system. That's why we want to make sure that that air is completely sterile for those kinds of procedures. But in the operating room, the majority of procedures that are being done are entering sterile organ spaces through the incision, and these remain open to the air. Yet it's fascinating that there are no similar standards for air quality in the US. However, Europeans have air quality standards for the OR, and our hope is that eventually this will be adopted in the US. And so a class 1, as we talked about a little earlier, you'd want to have an OR that has less than these 10 colony forming units during the major part of surgery, when the incision is wide open. And that's especially for orthopedic because of the implants in cardiac, but also in transplant units, bone marrow units, and burn units. The Europeans have class 2, less than 50 colony forming units, would be your general operating rooms, the emergency department, your pre-op areas, your OR quarters, any of the ICUs like the PICU, SICU, MICU, and acute patient rooms. We want that air to be clean. And then class 3, which typically are areas that we're not going to be worried about incisions being opened, like for instance, the cardiac intensive care unit, labor and delivery, your general nursing units, supply areas, radiology, exam rooms, kitchen, laundry can be just less than 200 colony forming units. Viral transmission is a risk in the operating room. During the pandemic, elective surgical procedures were curtailed pretty much around the world. And due to this, there was a reallocation of healthcare resources because of the risk of viral transmission to the patients and caregivers. Social distancing restrictions were put in place. Many patients were prevented from undergoing non-emergent procedures, and we had many restrictions on visitors, especially, any of your vendors and reps coming into the operating room. It has been shown the SARS-CoV-2 virus to be transmitted through the air. And these are small micron bioaerosols, and several studies have shown move through the air again on those platforms. These aerosols move around through air currents and then can be inhaled. There is particular risk from respiratory secretions that get expelled during the aerosol generating procedures in the operating room, so such as your surgical intubation, extubation, and the mask ventilation that will be done with the ventilation bag. And SARS-CoV-2, the role of positive pressure in the OR becomes controversial. A lot have questioned, we're doing surgery on a patient with SARS-CoV-2, are we pushing the virus out because of our positive pressure? And could that spread it to other surrounding perioperative areas? Shazari and colleagues at the Rothman Institute concluded that filtration of the operating room with devices that intake the air and remove microorganisms may be preferable to positive pressure laminar flow. And I would say this is not just a purification, but a scrubbing, consistent scrubbing of the air while the case is going on. A recent technical report from the European CDC concluded that where aerosol generating procedures have been performed, as we talked about the intubation and the bag valve ventilation, high efficiency particulate air HEPA filtration should be utilized. And we also have seen the use of residential and construction grade air purifier in patient care areas. But we should be cautioned because they can create turbulent outflow, and they're not compliant for electromagnetic compatibility for use in hospitals. And unfortunately, that's what a lot of hospitals did, was said, well, we've used HEPA filters for our construction site, so let's just get a bunch of those. And they really didn't understand that they're not appropriate for use in healthcare. The air quality in U.S. operating rooms, some of the current controls we have in place is first engineering air controls. We have dilution, filtration, pressurization, and disinfection. And those are described in the ARN by the CDC, ANSI, ASHE, ASHRAE, and some of their standards. The filtration should have a minimum efficiency rating value of 13 to 14 for the operating room. HEPA filtration would be 17. The pressure should be positive pressure in the operating room, because we want that to prevent any organisms with a negative pressure being pulled in towards the case. It's being pushed out away from the case. And your air needs to be exchanged about 20 times per hour. You have to check your temperatures and humidities every day to ensure you're within the guidelines. Evaluate your traffic control in the OR. ARN has guidelines on this, and CDC addresses this. Hair clipping outside the operating room. Hair is very contaminated with organisms. And so if you're clipping in the OR, especially it might be done for cardiac, neurosurgery, urology, and gynecology, since they're very sensitive clips, and you don't want that in the pre-op holding area. So they may do in the OR, but there are devices that there's a vacuum assisted device that can suck that kind of hair up first, so that it doesn't just move around the operating room table and into the air. And there are other issues we have to be aware of, with the surgical attire. And could the healthcare providers be having skin squames coming off their skin and moving through the air in the operating room? So the humidity in the operating room should be between 20 to 60% to help control microbial growth. The key thing, it supports the shelf life and product integrity of sterile supplies. Controlling the relative humidity can reduce transmission of certain airborne infectious organisms, including some strains of influenza. And it's also been talked about with the SARS-CoV-2 virus. Temperatures should be 68 to 75. We know that's a real challenge in some parts of the country. Location of the lights can increase the room temperature and also be an obstacle to the desired airflow patterns. But persistent hypothermia in the patient can contribute to an increased risk of SSIs. It can affect the movement of the immune system, as well as the platelets and things involved with clotting, so we can have problems with hemorrhage. So it's really important you think about the patient being warmed pre-op, intra-op, and post-op. There are different types of airflow systems in the United States for the operating rooms. The first one's called turbulent flow, where airborne contaminants are controlled with pollution. This increases the effectiveness of air exchange and distribution, but unfortunately it can speed up microbial dispersion. The second one is unidirectional flow, what might be called LAF, or laminar airflow, where the air travels in parallel lines and the contaminants are carried away at the same velocity as the airflow towards the exhaust outlets. And as I showed you earlier, it's not going to work at all if those exhaust outlets have equipment in front of it so that the air cannot get out of the room and get recirculated to get those 20 air exchanges per hour. And this system is designed to ensure that the airborne particles pass out of the operating room to get filtered. And then there's mixed flow, where you have unidirectional airflow, and this is only used to protect critical zones, specifically areas around the operating field. But there's really no consensus on the best airflow system for the operating rooms. Another issue and challenge for us in the operating rooms is the importance of hair and skin coverage. Full coverage of hair and skin is required by the ARN evidence-based guideline on surgical attire. And this is why. On average, an individual sheds more than 10 million particles from your skin every day. Approximately 10%, or 1 million of them, carry microorganisms on them. So when you have a room that has a lot of people in the room, you just have too many people in the room, and you're thinking about 1 million skin squames coming off their skin into that room, you can see why we have challenges with these air current transmissions of those organisms on the platforms ending up in the incision. The importance of hair and beard coverage is really important and stressed in the ARN guidelines, that there's full coverage of all head and beard hair, given that hair is typically laden with organisms. You can see what we call this skull cap. These very often do not cover the ears, the sideburns, or the back of the neck. I actually did a study once with orthopedic surgeons and anesthesia staff where we actually used these what are called contact plates in the laboratory. And we took cultures of the back of their neck. So they could see what was growing on the dandruff, the pimples, and the sweat on the back of their neck. And especially in orthopedic surgery where they're reaming and sawing and, you know, there's a lot of movement which could aerosolize any of those bacteria that might be on the back of the neck into the incision. And it was in that situation, it led the orthopedic surgeons to use a type of hair covering that was a hood, came right around their back of their neck, their ears, and it velcroed around the front of their neck after they saw those plates. Here's another question for the audience. In 1 year, the average person will shed more than how many pounds of dead skin? Do you think it's 0.5 pounds? Do you think it's 3 pounds or 8 pounds? So if you were on a diet, you can deduct 8 pounds a year. That's how many pounds of dead skin, those 10 million skin squames a day that come off of our body in a year, it adds up to about 8 pounds. It's really important that surgical masks be worn appropriately. And I think because of COVID, there's been a lot of education about masks and how masks should be worn. And at times wearing 2 masks and the difference between a medical, surgical, and an N95 mask. But here's one study. It was a prospective study of sneezes from orthopedic surgeons. And it concluded that following a sneeze, surgeons should regown and glove given the risk of contamination to the sterile field. And we know that's probably very infrequently done. But current guidelines recommend that a new surgical mask is used for each surgical case and should be changed when wet. And that really does depend on the healthcare worker determining whether they feel there's a lot of wetness that could have strike through on that mask. Smoke plumes are another issue. And there are now 3 states that have put acts into place about having policies in place in the operating room: Kentucky, Rhode Island, and Colorado. In the operating room, this smoke plume that gets generated by lasers and electrosurgery have been demonstrated to pose health risks the surgical personnel, the surgeons, and the patients. They can develop upper respiratory irritation. That smoke plume could have the human papillomavirus in it, or HPV. It could develop a surgical infection from the smoke plume if it does have bacteria that gets into the smoke and lands into the incision. And also there have been cases of metastatic melanoma that have been traced to smoke plume. This is very important for you to have some kind of a protocol in place to deal with smoke plume in your operating room. There are two categories of technology that have been designed to remove smoke plume from OR environments. You probably have seen or used a smoke evacuator system that vacuums the smoke at the surgical site through an air filter. There's also a very unique, one-of-a-kind mobile unit that you can move into the operating room that has high efficiency particulate air, or a HEPA filter, with UVC disinfection that will take all of the air throughout the operating room. It will purify it through the HEPA filter and UVC and disinfect it and create a safer environment in the operating room. And this type of system has been shown to be effective at removing both airborne bacteria and the surgical plume. So some of the human factors that affect the OR air quality are coughing, talking during surgery, or sneezing, which then make the mask get wet and they don't change it. The skin shedding we talked about of 10 million skin squames a day. There's even hair shedding, as I mentioned, on the back of the neck, around the ears, from dandruff and sweating, or maybe little pimples that are there. Movement of people constantly in and out of rooms with a lack of respect for the doors being closed, especially in any kind of implant surgery. So that when they open that door, they don't get a whoosh of air that goes right over that surgical field. Then the heater cooler exhaust air contamination, as you saw, causing an outbreak. The 21st century operating room airflow pattern, it should look like this. This concept of, say, laminar flow, which should come down around the field, the personnel that are at the field, grab that air with that force and push it down to the floor and push it out the exhaust grills. And that's how it gets to deactivate the pathogens and displace them out through those grills. But unfortunately, with all the equipment we have in our ORs these days and table setups and so forth, it's very difficult for the air to consistently get out of these rooms. For the limitations of engineering controls, the standard OR airflow results in a clean central area surrounded by a more contaminated area. And that's driven by poor airflow, the human activity moving around the periphery of the field, all those door openings that I mentioned, and even floor contamination. So this is referred to as the dirty donut, where air can be as much as 100 times more contaminated than that cleaner center of the room, where one of those filtration systems coming down around field and pushing it out to the exhaust vents. That's what we hope will happen. But then what happens is it gets mixed in with this dirty air, what we call the dirty donut. Now, adjunctive air decontamination technology would be a piece of equipment coming in, this innovative technology that has a HEPA filter with UVC in the machine. And you place it in the corner of the room. And what it does is it takes that dirty donut and it constantly cleanses it. It's purifying it so that you have now what's called a clean donut, and it replaces that dirty donut of contamination. Now whatever filtration you have is going to work better because it's coming around the field, but now you have clean air that would have been contaminated in the past. Adjunctive air decontamination technology is described in the CDC guideline for environmental infection control in healthcare facilities. And they quote, as a supplemental air cleaning measure, UV germicidal irradiation is effective in reducing the transmission of airborne bacterial and viral infections in hospitals. And there are many hospitals right now, because of COVID, using these kinds of UV robots, either isolation rooms or maybe a COVID unit. So that's been used a lot. But the uniqueness of adding HEPA filter with UVC is really key. But also in ASHRAE guidelines for patient care construction, they state recirculating HEPA filter units used for infection control without heating or cooling coils are acceptable. for use in the operating room. Now, there are other air decontamination technologies that you might see in an operating room. It might involve filtration, like a surgical helmet system, or as we talked about, laminar flow. UVC disinfection, as I mentioned, there are some that can be actually built into the walls, up into the ceilings. There are some that are movable robots, as I mentioned. It's also a system that uses dry hydrogen peroxide and puts out the constant activity to clean any kind of bacteria, viruses that are in the air. And then there's this filtration plus disinfection, this novel air scrubbing technology, UVC plus the HEPA filtration. Here's another question. There are 3 UV light wavelengths, UVA, UVB, and UVC. Which wavelength is germicidal that will kill funguses, bacteria, and viruses? And the answer is UVC. Let's look at the surgical helmet system of filtration. The current positive pressure surgical helmet systems have been found to be ineffective in some studies and actually were associated with an increased risk of SSIs in others. That was felt to be due to the positive pressure inside the suit, which could carry air and particles through unsealed areas around the surgeon's cuff into the operative field. There is alternatively an older negative pressure type Schonley type body exhaust suits, and they were reported to be effective in reducing contamination of the surgical field. Now, in addition to having these are not to prevent necessarily surgical site infections, but they're very useful for a surgeon not to get splattered with blood or body fluids, especially in orthopedic surgery. But we should be then considering the use of a mask so that their organisms are not coming out of their nasal passages and mouth and then going down, as it mentions, outside unsealed area around the cuffs onto the operative field. Laminar flow was originally recommended in order to maintain a flow of clean air during the surgical cases around the field. However, research has shown it to be ineffective. And in some cases, it actually increased the risk of SSIs. So this has not been shown to be a system that's going to prevent SSIs. Another system delivers HEPA-filtered clean air immediately adjacent to the surgery site. It creates an airflow layer directly over the surgical wound to repel bacteria. It's really not widely used because the surgeons feel that it impedes their freedom of movement by the rest of the surgical team and trying to get another piece of equipment with this hose and put it up on top of the field to try to, filter and take out this airflow through a HEPA filter. There's another unique technology that uses what's called white light disinfection. So here's actually an operating room that has the white lights in. This was a brand new hospital. They put the lights into the operating room when they were building it. And what's interesting about it is that it's set so that when the room is vacated, it automatically turns into this very deep indigo color, indicating that it's disinfecting the room. So it's more of a passive disinfection system. You don't have to have lug around these UV robots at the end of a terminal cleaning of a case. This will just continue all night long to disinfect the room. And here's an example of that dry hydrogen peroxide. It does require a capital expense to get these units up into the ventilation system. In a typical facility, it will handle not only airborne microbes and surface contaminants, but things like pests like flies and lice and bed bugs, odors. It will take out the odors, cross-contamination, high vac distribution and recontamination in, say, an emergency room. So it's starting to be used. I know a lot of hospitals started to put this in their break rooms so that they could have the staff go back to having breaks together and have it safe with the COVID situation. This is the novel air scrubbing technology that I mentioned, where it takes the UVC and HEPA filtration and it scrubs the air constantly as it's on, working in an operating room to create that clean donut. There have been peer-reviewed studies that report reduced air bacterial levels in the operating room about 50 to 60%. And a study of more than 500 arthroplasty procedures concluded that the use of this intraoperative air decontamination system had a statistically significant overall reduction in their prosthetic joint infections. There's been a growing body of evidence that supports the presence of airborne SARS-CoV-2 as these small droplet bioaerosols in healthcare settings. So to reduce the risk of transmission, improvements in room ventilation are advocated by CDC and WHO, including supplemental air filtration and disinfection. CDC just recently updated their guidelines on ventilation in buildings. In a recent study testing the efficacy of this UVC and HEPA air decontamination mobile unit, that's the other great thing about it, it does not require operating rooms being shut down and retrofitted with new lights or newest system up in the equipment up in the ventilation. You just move this into the room and it goes to work. And they found a decontamination of the air of SARS-CoV-2 virus 100%. It was eliminated during 15 trials when it was compared to only a 40% reduction by 2 control devices. One was inactive and one was UV only. So the addition of that HEPA filtration with the UV has a wonderful effect on getting rid of not only bacteria in the operating room, but the viruses like SARS-CoV-2. So in conclusion, current standard methods of providing safe air quality in the OR and throughout the healthcare facilities are limited, providing positive air pressure, increasing the air changes per hour, ensuring hair coverage, long sleeves, traffic control, and in some operating rooms, they have put into place HEPA filtration. These methods alone have been proven ineffective, and that's been shown by the outbreak in cardiac surgery and the continued outbreaks we have in SSIs, despite all of these measures were put into place on checklist, on the SKIP initiative, the antimicrobial therapy. We still have lots of SSIs. And so the use of surgical helmet systems in laminar flow have also had limited value. And we've been using these for years, and we haven't had significant reductions in SSIs with all of this equipment that's been used in healthcare. Most hospitals now are in the process of attempting to simply restart elective surgeries while in the midst of a pandemic. And that's a challenge because people are still concerned about the bioaerosols from SARS-CoV-2. And an air decontamination technology can really serve as an adjunct to your engineering controls for improving your air quality in the operating room. Especially, you could prioritize it first for implant procedures, which has been done by many of the hospitals using this innovative technology. And air decontamination technology can serve as an adjunct to your engineering controls for improving air quality for SARS-CoV-2. There's been a lot of use of this type of technology in gyms, in hospitals, and other kind of emergency room settings where they want to filter the air and make sure that they kill the SARS-CoV-2 virus and its transmission. Thank you for listening to this presentation. There's continuing education credit provided with Terry Goodman and Associates. It's been approved by the California Board of Registered Nurses. And to earn your certificate for 1.2 contact hours, you must miss no more than 10 minutes of the webinar, complete an online evaluation, and you'll receive an email invitation within 48 hours. And if you do not receive the email, check your spam folder. But if it's not there, you can contact Terry at terrygoodman.com. And thank you for listening to this presentation on the prevention of contamination in air, especially in operating rooms.
Thanks, Maureen. That was fabulous. Really enjoyed listening to the presentation and the information. And we've had a couple of questions come in from our audience. We do have a few minutes. If you don't mind, I'm going to go ahead and ask you these questions. So first of all, the first question, you talked about some of the hands-free environmental disinfection technologies, visible light disinfection, dry hydrogen peroxide, and HEPA plus UV disinfection. Would the last, the HEPA plus UVC, also help to reduce the burden of pathogens on hard surfaces in the operating room?
Yes, they would. I mean, that's what's unique about it because, you know, the ones that have to be put into the ceiling, into the light fixtures, either or into the ventilation system, they're coming down to deal with the airborne contaminants. But as you saw with the dirty donut, all that air that's moving around through the environment, landing on the surfaces from the activity, sort of from the neck down, you know, in that dirty donut from people moving around and doors being open and closed. That's what's so unique about this HEPA filter with UVC machine that can be put into the corner of the room and then start just scrubbing that air. And as a result of that, it's going to take the organisms, the velocity of it's going to take the organisms off some of the surfaces and prevent it from getting down into the incision. So yeah, I think it's also easier. I mean, for a hospital to be able to use that than having to retrofit, I call it, you know, getting into ventilation systems, like I said, of putting new lights in to have a reduction in air contamination. So yeah, definitely. This one I think is just a more useful product.
Yeah, that makes a lot of sense. Taking that airborne bacteria, eliminating that before it can land on surfaces. Yeah, that's great. Okay, the second question was, since the start of the pandemic, our OR has been insisting on using PAPRs. Is this safe for the quality of air in the operating room?
Well, these positive air respirators, purifying respirators, or PAPRs, they can be used, but if they're using one of those helmet systems, as I mentioned earlier, they should have a mask on, you know, so that they're confining and contain their own nasal organisms that could come out if they happen to sneeze or cough during the case, or they're talking a lot. So PAPRs are being used. There's some, actually, there's a new one that looks almost like a CPAP machine. It's one that's a portable one that they're using in a lot of nursing environments, because the nurses don't like the whole, you know, the typical PAPR with the hood, and then they have a battery pack that they have to wear around their waist. And so there's all kinds of interesting technology that's come out since then. But the key thing is the mask. You know, if they're going to use something like this in the operating room, that you have to still protect your own face and your own nasal organisms that might come out.
Yeah, that makes sense. Okay, the last question that came in is, should surgical masks be changed at any point during long cases that last more than an hour?
Yeah, great question. And there are 3 good studies that have been done related to the operating room mask, we'll call it. And they found that those masks pretty much should be changed between 60 to 90 minutes in 3 studies. Now, a lot of the cases get done, you know, orthopedics, a lot of those will get done under 2 hours, a lot of surgeries. But, you know, if you've got a spine case, I remember working at that orthopedic hospital, you got spine surgery 10 to 12 hours on a large, you know, long scoliosis case. And so that's something they have to consider, is to keep changing the mask maybe, you know, every hour to an hour and a half. There was one other study where they looked more on the outside use of these masks, and which is going on right now with COVID. And those should only be used about 2 to 6 hours. And we just know that people are keeping their masks. They're not throwing them away, one a day. Their respirators, their HEPA filter, I mean, their N95s are being reused. Their cloth masks. So that's why I think the CDC has been concerned about, and it's tried to come out recently with some new guidelines about how to appropriately wear masks. And that highlights it, that you're probably going to only get 4 to 6 hours protection in a mask outside the operating room. But, you know, of course, it's going to be shorter when you're over a surgical field and there's a risk that you get strike through, we call it, where it gets wet. And then anything from the inside is just going to migrate out and pass through the outside if it's wet.
All right. Well, thank you very much for sharing your amazing expertise. I love listening to you, and I always learn a million things. Thanks very much, Maureen.
Thank you, Sue.